All of you, this is the Continent Diversion Options Updates and Surgical Advances Workshop, so I hope that's where you all wanted to be. We are welcoming today Dr. Don Schiller, who has his wife, Roberta, with him. Dr. Schiller is a specialist in general surgery in Los Angeles, California, and a fellow of the American College of Surgeons. He graduated from the Albert Einstein College of Medicine in the Bronx, New York, and did his surgical residency at UCLA Medical Center. He holds many leadership positions on each of the hospital medical staffs where he has attending surgery privileges. For over 20 years, Dr. Schiller has performed continent ileostomy surgery using the Barnett version of the Cook pouch, thereby providing patients a continent ostomy alternative to a conventional ileostomy. Welcome, Dr. Schiller.
Thank you. So today we are going to talk about options for people who need to have their colon removed. So we're talking about people with ulcerative colitis, familial adenomatous polyposis, FAP, and some of this applies to people who have had Crohn's disease limited strictly to their colon without any small bowel involvement. But that's a little bit of a different topic. So let me just start off while you're looking at this slide about the history. Let me tell you about the 90% rule. Studies have been done comparing patients in terms of patient satisfaction and the quality of life. 3 groups. Conventional Brook ileostomy, we wear an external appliance. The continent internal pouch ileostomy, originally Dr. Koch created it. I do the Barnett type of continent ileostomy. We'll see all about that in a minute. And ileoanal J-pouch. So those 3 groups have been compared to see how satisfied people are. And it's 90% for each. 90% of people with a conventional ileostomy will do anything from skydiving to scuba diving. You make a good emotional, psychological adjustment. 90% of people with a continent ileostomy, an internal pouch, the same, and the same for J pouches. But not everyone is in the 90% rule, obviously, and that's a lot of what we're going to talk about. So in the early part of the 20th century, we could do ileostomies, but they were not compatible with going out of the house. And I'll show you some pictures in a minute. The modern day ileostomy was developed by Dr. Brook in England in 1952, and a few months later, the same procedure described by Dr. Rupert Turnbull at the Cleveland Clinic, but it's called not the Brook-Turnbull ileostomy, the Brook ileostomy. But Dr. Turnbull gets tremendous credit for developing enterostomal therapy nursing. And he's really the father of ET nursing in conjunction with the nursing profession as well. The Koch pouch was first designed in 1969 just as an internal pouch with a stoma that you catheterize, but then a valve was added in. We'll see all about that in the J pouch in 1978. So you can see on the top, if you have ulcerative colitis, you have your choice, depending on your medical indications, which is appropriate for you. Crohn's colitis, we have question marks for pouches because there's an increased risk of developing Crohn's disease in a continent pouch later on. Familial polyposis, all 3 options are available. If you have Crohn's involving your small bowel, enteritis, enterocolitis means small plus large bowel, then we don't make pouches. If the small intestine is not healthy, it's dangerous to create any kind of internal pouch or reservoir. And if you've had your colon and rectum removed, including the anal canal and the sphincters, you can never have a J pouch, but you can have that converted to a continent ileostomy. So here's kind of the ballpark functional results. People with a Brook ileostomy, emptying their external pouch, the appliance varies depending on how much you eat and how full you want the appliance to get. The continent ileostomy, Koch, BCIR pouch, T pouch, approximately that. And the J pouch, as you see it on the slide. And we'll go through different variations of this. So here's a normal human anatomy. And with a J pouch, we want to take out all the rectum. If we leave a little bit of this section, the transitional zone, there's a risk of continued colitis, even cancer. And patients with a J pouch do need to have an annual flex egg or a little anoscopy looking in at that area. So with the J pouch, we make a pouch. Sometimes it's a W, sometimes it's an S, but mostly it's a J. And then it's connected to the upper part of the rectum or lower down, depending on that patient and the surgical technique. And this is an old slide. It's 20 more years old, but it's still very appropriate because things haven't changed so much. And this really is talking about stool frequency. How many evacuations do you have? When you have a J pouch, well, let's back up. When you have colitis, active colitis, you know all the bathrooms between your house, your office, your school, your church, your market, because when you get the urge, you can't wait. With a J pouch, you could defer evacuation from that first signal for 45 minutes to an hour. You can't wait indefinitely. But the range of bowel movements per day is 4 to 7, more or less. And some patients need medication to reduce the amount of stool they're having. The other thing we are concerned about with J pouches is control, continence. And results have improved somewhat from this slide. More people have perfect control day and night. As we sleep, our muscles relax, even our sphincters, so sometimes there's a little bit of leakage at night. But the vast majority of people with a J pouch don't have problems with incontinence. That's why the operation is successful. If more people had incontinence, it wouldn't be done so much. Now here's a ileostomy. This is not a male genital organ. It's an old type of ileostomy called a Dragstead ileostomy. We brought the intestine out of the body like a stoma, but it just was a long segment covered with a skin graft. Here's the opening. And this was before enterostomal therapy was invented, appliances were invented, so the patient would have to put a belt on and like a collecting system, a bucket, a plastic container, and things would just drip in. So that wasn't very good. And that was called the Dragstead, Dr. Dragstead of historical interest. So here's a typical bronchioliostomy stoma. It obviously has to protrude above the skin so the waste goes directly into the appliance. Another good stoma in a patient with a different body build. Here's a stoma that's retracted. The intestinal waste is very caustic to the skin, and that's a major concern. Here's a stoma that's prolapsed. It's much longer than it should be. The intestine pushes out, kind of slips through the stoma, and rubs in the inside of the external appliance, and this is something that requires surgery. Here's a stoma of a continent ileostomy. And you can't tell from the stoma whether this is a BCIR, a Barnett continent intestinal reservoir, or a Koch pouch, or there's another type of continent ileostomy called a T pouch, which is pretty much localized to one medical center that does them, USC. Some people are fortunate enough, they have very little mucus from their stoma, and they literally just put a Band-Aid over it. No gas or waste comes out of that stoma until you put in a catheter to drain it, and we'll go through that as well. Sometimes the stoma is a little slit, and you have to kind of stretch the skin to see it, and then put the tube in. And here's a patient wearing a patch designed for the stoma. This is just for demonstration. Obviously, if the catheter was all the way in to the pouch, waste would be dripping out that open end. So it's just a little bit in, just for demonstrative purposes. And most people will sit on the toilet, put their tube in, and the waste drains directly into the toilet. But some people like to stand, but this is just for demonstration. Some men like a really long catheter. They stand to urinate, they stand to evacuate their pouch, and if the catheter is long enough and there's no splatter, if it works for them, it works for them. But most people just sit down like anyone else having a bowel movement. So indications for a continent ileostomy is someone who's already had a bronchioliostomy is having difficulty with it. A malfunctioning of bronchioliostomy includes physical dysfunction, allergies to the appliances, frequent episodes of leakage, loss of the seal, retraction, hernias, prolapses, all the things that can lead to need for more surgery. So such a patient could have, instead of repairing or fixing their conventional ileostomy, they could have it converted to a continent ileostomy. A patient who's had a J pouch where it hasn't worked, and we'll talk about long-term results in a few minutes. But if a J pouch result proves unsatisfactory, too many bowel movements per day, too much urgency, fistulas, other complications that occur with J pouches, that patient has two options: a conventional ileostomy external pouch or